Good evening and welcome. I'm James Liu and I'm a librarian at Stanford Health Library. Thank you for joining us. Our talk tonight is entitled Prostate Cancer Screening and Treatment Options. It's my pleasure to introduce our speaker, Dr. Randall Stafford. Dr. Stafford is a professor of medicine at the Stanford School of Medicine. He's also the director of the program on prevention outcomes and practices in the Stanford Prevention Research Center. His research emphasizes clinical issues and health behaviors related to chronic disease. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen. At the end of the talk, Dr. Stafford will answer as many of those as well as the pre-submitted questions as possible. Dr. Stafford, I'll turn it over to you.
Great, it's so nice to be here. And thank you for that warm introduction, James. And it's my pleasure to talk with you today about prostate health. And I am going to focus on prostate cancer, but I do want to include a couple areas of prostate health in addition to cancer, namely benign prostatic hyperplasia, or BPH, and prostatitis. So let's get started. First of all, in terms of what I'll talk about today, I'd like to tell you a little bit about what the prostate is, what it does, where it's located. Many of you may not need that introduction, but I think it's good to review the anatomy. I also want to talk about these three common prostate health issues: benign prostatic hyperplasia, prostate cancer, and prostatitis. My point that I want to really get to you, and this is particularly important to me as a primary care doctor, is that what's good for the heart is also good for the prostate. And I think in general, both in prevention and treatment of these prostate issues, we've lost sight of how important health behavior issues are to these various problems. So let's just review a little bit of where the prostate is. As you can see here in purple, the prostate is lying just underneath the bladder and just above the base of the penis. You can see that this bone here is part of the pelvis. So in some ways, it's quite well protected. And the prostate is very close to the rectum here, which we'll learn in a little while, is very important in terms of some procedures that are done to look for prostate cancer. I also will just point out that the prostate, because it is part of the reproductive system in men, is also hooked up with the testicle through this long vas deferens here. And there are other components of the reproductive system that hook in to the prostate. We see just a slightly different view here, basically just looking at the prostate in cross-section. We see the bladder above it right here. We see the vas deferens coming in from the testicle on each side. We see the seminal vesicle here, an area where sperm are often stored. And then we see the urethra, which goes through the middle of the prostate, the center of the prostate, and eventually exits the body at the end of the penis. So this is just an orientation to where things are, and in some ways, how small this prostate gland is. But I think its importance in terms of health, particularly among older men, is sizable, and in some sense more sizable than the size of the gland itself. So what does the prostate gland actually do? Well, first of all, it's important for prostate fluid production. The prostate gland produces part of the semen, and in particular, it helps the sperm keep mobile and keeps them viable for a longer time because of some of the secretions produced by the prostate. The prostate is also important for muscle contractions during ejaculation. The covering of the prostate and within the prostate is smooth muscle. And this is very important because it has this purpose during ejaculation, but it also becomes important with some problems of the prostate. And then also the prostate secretes a particular molecule called the prostate-specific antigen. And this is a particular chemical which helps semen flow more freely, keeps it in liquid form rather than as a gel. In some ways, it's an interesting organ because it's not at all needed for survival, but is important for reproduction. So the typical medical school question that always has the urologist, the expert on the reproductive tract of the man, has him kind of driven crazy by this question: is it really worth all these problems that are created by the prostate? And some of the answer to this is that from an evolutionary standpoint, we do pretty well in terms of prostate health until we reach our older years. And by that time, of course, reproduction is not as important, although it is still possible in older men. And in some sense, there's this kind of evolutionary trade-off between early function and effective function early in life and problems later in life. In some ways, there continues to be debate about whether the process of benign prostate hyperplasia should be considered an abnormal situation or simply part of normal aging. It's also likely that the prostate helps maintain the health of the reproductive system, particularly fighting off infections and in some sense being a barrier to the entry of bacteria into the male reproductive system. And then finally, I want to just point out that like all other organs, the prostate is affected by system-wide issues such as inflammation and infection. So the prostate is in this position of not only doing these particular functions, but it's very much at the mercy of what's happening in the body metabolically. So I want to talk about three common prostate health issues. The first is benign prostatic hyperplasia, or BPH. I'm going to be talking a little bit about some of the causes and definition of this, as well as how this impacts daily life. And I want to get across the point that BPH is mostly an issue because it can severely affect quality of life. Prostate cancer is a different animal. I'm going to talk about its the risk factors for it. I'm going to particularly focus on early detection and screening options, and just talk a very little about treatment options. Now, as a primary care physician, in my patients who have prostate cancer, this is an issue that the medical oncologists, sometimes the surgeons, and sometimes radiation oncologists are basically tasked to help with. So this isn't something that I do a whole lot myself, but I do want to give you an overview of that issue of cancer treatment. And then also, I'm going to briefly just talk about prostatitis. This is inflammation of the prostate gland, go into a little bit of what are the different types of prostatitis and some of the symptoms and treatments. So in terms of benign prostatic hyperplasia, or BPH, what we basically have here is the enlargement of the prostate gland. And you can see it here right underneath the bladder. When it becomes enlarged, it tends to become inflamed and tends to cause difficulties for the urethra, which is passing right down the center of this solid, somewhat spherical gland. This passes right through the center. And BPH is very common. By the age of 60, about 60% of men have some, at least mild enlargement of their prostate gland. By 85, it's almost everybody, about 90% of men. This is caused by a series of events in the body that may be linked mostly with aging, but also have to do with hormonal changes, and particularly the increase in a molecule called dihydrotestosterone. This is a type of testosterone, and in later years, much of the testosterone is converted to this DHT, which has this effect of creating enlargement of the prostate. Some of the behavioral factors are critical for BPH, including obesity, low physical activity level, a diet high in saturated fat, and alcohol intake. All of these behavioral factors make benign prostatic hyperplasia more likely to occur and make its presentation worse. So, what are some of the symptoms of BPH? You probably are familiar with some of these, but I'm just going to run through the listing of these symptoms. You know, when the prostate is only mildly enlarged, there really are no symptoms. And it's only with greater enlargement that we start to have problems with our lower urinary tract and causing this constellation of symptoms called LUTs, lower urinary tract symptoms. One of the most important parts of this is urinary frequency, the idea that we need to urinate more frequently than usual. And often there's an urgency to urinate, that we have a stronger than normal urgency to urinate. This frequency of urination is particularly disruptive during the evening when men need to get up to urinate because of their BPH. And we often have a kind of metric for thinking about, well, how much is tolerable? Because in some sense, this is a natural part of aging. And how many times a night do we get to the point where it's clearly interfering with sleep? So for myself, at the age of 65, I would say that most evenings it's one time, a couple of days a week, maybe twice an evening. But for me, the level of nocturia, or this waking up to urinate, is pretty manageable. It doesn't really interfere with my sleep in any big way. So I'm certain that I have benign prostatic hyperplasia, but it's mild, and the amount of nocturia is easily accommodated. On the other hand, if I was getting up 5, 6, 10 times a night, it would be a different story. And that might be an instance where we want to do something more than just keep track of the symptoms. In terms of other symptoms, there is often a weak urine stream. Our urination is less forceful than it used to be. There's also this problem of hesitance and intermittency. So there's difficulty starting and stopping the urine stream. And often there is starting, going for a little while, stopping, going again, and kind of this idea that it takes multiple times to actually feel like we're done urinating. And part of this is that the bladder often never empties entirely. With normal function of the bladder and the prostate gland and the urethra, the urine should be completely devoid of, the bladder should be completely devoid of urine after urination. With BPH, increasingly this doesn't happen. The bladder still has some urine in it. Erectile dysfunction is also a common kind of association with BPH. It's not exactly clear what the mechanism is. Very often, the same things that cause BPH are also interfering with erectile dysfunction. And another symptom is dribbling after urination. And this basically is because the urethra doesn't close entirely. So these are the main symptoms, and these may be extremely mild, as they are in my case, or they may become very severe. And how we treat BPH really depends on how severe the symptoms are. I'm sorry, also, I should put in straining. So the idea that there's often kind of use of the abdominal muscles to get urination started. And in the most severe instance, there's this problem of retention. So this is where the bladder, sorry for the misspelling there, has this bladder outlet obstruction. And this means that urine is essentially stuck in the bladder. And this is the one part of BPH which really is an emergency and really can cause a lot of both acute and chronic problems, particularly if the back pressure increases on the kidneys. So as I was saying, the treatment often depends on the severity of symptoms. So let's take a look at how common BPH is. So prevalence is the number of people, the fraction of people in a particular age group which have this problem. And we can see in the United States that if we have two definitions of BPH here, one is symptoms that are severe enough to cause inconvenience. And we see that basically they follow an increasing prevalence with each year. We can also define BPH as more anatomical, looking at the types of cells in the prostate and seeing that they're enlarged. So this includes people who are not having any symptoms, but may be at risk for future symptoms. And we can see that both of these lines increase with age. You can see that by the time we get up to 80, at least 80% of the population of men has BPH. A slightly smaller fraction, about 20% less at any particular age, are actually having noticeable mild to moderate lower urinary tract symptoms. And I thought it was interesting just to kind of compare this with rural Nigeria. The numbers are a little bit less. So we see that for men over the age of 90, 43% of them have symptoms. So we're talking more about 60% in the US for an even slightly younger population. But you can see that it has the same pattern of increasing over time. And it's quite surprising that even in this rural environment where most of the men are actually living a pretty healthy lifestyle with relatively rare obesity, lots of physical activity, a diet that may not necessarily be ideal, but certainly one that doesn't include a lot of meat. And we see that while the rates are lower here, there is this sizable increase with age. In terms of preventing and treating BPH, I want to get across this idea that health behavior change is a very potent way of both preventing as well as treating BPH, particularly when we're talking about more mild symptoms or mild enlargement of the prostate. And things like losing weight, becoming more physically active, eating or moving towards a plant-based diet are all helpful in that regard, both for younger men who are trying to prevent or forestall the occurrence of BPH, and for those men who have BPH. And I would say that these are important regardless of how severe the symptoms are. For more severe symptoms, of course, we're going to add other strategies onto these health behaviors, but these health behaviors remain very important. Reducing alcohol can also be beneficial, both for prevention and for treatment. And in general, I kind of lump these things into a category called anti-inflammatory lifestyle. So these are the things that we know reduce the amount of inflammation systemically in our body. And I want to make the point that the prostate, in some ways, is a bit of an innocent bystander when it comes to this inflammatory process. And for mild symptoms, we may move on to some other types of behaviors that can be helpful. Restricting fluid intake before bedtime is often helpful. Avoiding diuretics near bedtime. And this doesn't matter whether these are prescribed drugs that are diuretics or whether we're talking about alcohol or caffeine, which are also, in some sense, natural diuretics. Pelvic floor exercises may be very useful in terms of the function of urination and having less dysfunction in urination. And these basically are Kegels for men, where during the stream of urine, during urination, to start and then stop that urine stream intermittently. For more severe symptoms, I think it's very important to know that there are some really effective medications out there that can help. These include alpha blockers, in particular a drug called tamsulosin. These relax smooth muscle, and the prostate is very much a smooth muscle gland. And reducing the tension or the contraction of smooth muscle allows the prostate to relax and allows the urethra going through the very center of it to be a little bit more open than it would be otherwise. We also have a set of drugs called 5-alpha reductase blockers. Finasteride is one of the most commonly used ones. These are drugs that block the processing of hormones, particularly testosterone, and prohibit or reduce the conversion of testosterone into dihydrotestosterone. And this basically reduces the amount of signal that the prostate is getting that causes it to enlarge in the first place. And then kind of some interesting new research shows that these phosphodiesterase 5 inhibitors, or PDE5 inhibitors, like Viagra, sildenafil, they not only will help with the erectile dysfunction part of BPH, but they may actually reduce the enlargement of the prostate gland itself. So they may help erectile dysfunction in two ways, both by permitting better erectile function, but they may have the secondary effect on the prostate itself. And then in those cases where the drugs are not sufficient to improve quality of life, there are several minimally invasive strategies for removing or destroying part of the prostate. And the idea here is if the mass of the prostate is reduced in size, it will no longer impinge or squeeze on that central urethra going right through the center of it. So I want to move on to talking about prostate cancer. And here what you see are the prostate gland, again, located between the base of the penis and the urinary bladder here. And in this case, we can see these little nests of malignant cells that are growing within the prostate. Now, prostate cancer is the most common non-skin cancer in men. I do want to make the point that even though there are 250,000 new cases in the US annually, that this is a cancer with incredible variation in severity. So it ranges from very slow growing, low risk cancer to very aggressive, high risk cancer. And in some sense, I think it's important to recognize that this is kind of like multiple cancers that have their own natural history, have their own way of showing up. And in a way, for convenience, we bundled these together. But in some sense, it's very useful to think about this being multiple different types of prostate cancer that we all kind of lump together and we screen for together. But some of these cancers turn out to be very aggressive. They're quick to metastasize, that is, to leave the local area of the prostate and move to other locations within the body. And they're often diagnosed very late. This is one extreme. The other extreme are very indolent prostate cancers. These are very slow growing and in many cases never metastasize. So what's important here is that these slow growing prostate cancers are incredibly common. And based on biopsies and autopsies among men over the age of 80, it's incredibly common. So for instance, in the range of 50 to 60% of men in this age group will have within their prostate some evidence of malignancy. So this is really, in some sense, a very challenging type of situation, because there are some prostate cancers where, in essence, we wish we never knew about them, because in large part, they cause more worry than they do actual biological damage. On the other hand, there are these very aggressive prostate cancers that we want to be on the lookout for. Yep. So this is just an illustration of this is kind of worldwide estimates of the risk of developing prostate cancer. These are from Nordic countries, but you'd find very similar patterns in the US. And what we see here in red and green are the incidence of prostate cancer in those two groupings of Nordic countries. This is the rate of new cancer per year. And we can see that over time, it has slowly gone up in these two populations, but particularly since the mid-1990s, there's been this incredible increase in rates of prostate cancer. And these have flattened out a little bit in more recent years, but they are still very high and quite a bit in excess of what we see in this period of the 1960s, 1980s, early 1990s. And you can see that even though it's a bit more subtle here, we've also had an increase in the number of men dying of prostate cancer over this time period. So one of the implications there is that a lot of this new prostate cancer is relatively mild in nature. And you could also kind of see that if we think about the number of incident cases, that is the new occurrence of cancer, compared to how many people are dying, we have a ratio that is as large as 3 or 4 here, which is more than it was back here, where we have a ratio of less than 2. In terms of prostate cancer staging, this is very rudimentary, but I think it's worthwhile just mentioning the general strategy for staging cancer. And staging is important because survival is very much tied to what stage a cancer is discovered. So stage 1 really means that there's just local growth of cancer, and that by and large, there has not been very much anatomical disruption of how the prostate actually works. Stage 2 is these nests of cancer cells have grown bigger, and they're starting to disrupt the local anatomy or histology within the prostate glands, but they haven't really distorted the prostate itself. They're contained within the prostate. In stage 3, we have advancing growth of these nests. And what we see here is that the cells have outgrown the limitations or the capsule that surrounds the prostate. So in some sense, at this point, we can say that the prostate cancer cells are no longer local. They are spreading past the boundaries of the prostate themselves. And then stage 4, or metastatic prostate cancer, is one step further, where this local extension and invasion has gotten so bad that cells are leaving the local area with the potential of setting up shop in other places of the body. When we talk about risk factors for prostate cancer, I think that one of the important questions is prostate cancer related to BPH? And this is actually not quite as easy to answer as it might seem. In some sense, I think we feel pretty comfortable that biologically, there's nothing going on in BPH that is going to necessarily lead down a pathway to prostate cancer. On the other hand, both BPH and prostate cancer have some common risk factors. And so you're going to see these two problems in men more often than you would expect by random chance. Now, of course, age is going to be a big factor in both of these, but so are some of these behavioral factors that I talked about earlier for BPH. So to say that BPH is not associated with prostate cancer is actually incorrect, because the two do travel together, but they may travel together because of these risk factors rather than anything innately going on within BPH. So most cases of prostate cancer are over the age of 65. This is a cancer that becomes much more common with older age. And as I said, in autopsies of very old men, very common to find this type of cancer, often in its more mild form. Being African American is a risk factor for both the occurrence of prostate cancer and more severe or more invasive prostate cancer. Latinx and Asian men tend to be at lower risk compared to white or European ancestry men. There's also a very important genetic association. BRCA1 and BRCA2, these are the breast cancer modulating genetic markers, often found in Ashkenazi Jews. Just as in women, these cause breast cancer and in some cases ovarian cancer, in men, they're associated with prostate cancer. Diets that are high in red meat and have a high fat intake also are risk factors for prostate cancer, as is obesity, where men who have extra weight have both a greater incidence and greater progression of prostate cancer. There are some toxic exposures, including Agent Orange and cadmium, that seem to predispose or promote the occurrence of prostate cancer. So I want to delve into issues around prostate screening. And this is a somewhat complicated topic, and I think that it's worthwhile to step back a little bit and basically say, when we have a strategy for screening, what are the sort of things that we need that screening to do for it to be effective? So I wanted to get across here that, for any screening strategy, including other cancers, and let's just contrast prostate cancer screening with cervical cancer screening, which is usually done by pap smear. In each of these cases, for screening to be effective, it needs to detect cancer early enough to allow intervention. It also needs to allow these interventions to change outcomes without undue adverse effects. So in other words, not only do we need to be able to act early, our way of acting needs to change the cancer outcomes without creating too much other problems for individuals. If we're thinking about screening for something like prostate cancer, which is only going to occur in about 1 out of every 1,000 men, then it has to be low cost. It's not going to be feasible to have effective screening if there's a very costly screening mechanism. And in terms of how the test performs, we often talk about test performance or screening test performance in 2 ways. We talk about how specific a test is and how sensitive a test is. These are different things, and I want to differentiate them. For a test to be specific, it means that when the test is positive, we're pretty sure that it really is cancer. And so the way that this breaks down is when we have false positives. That is, the test is high, but there's no cancer present. Kind of the flip side of screening is that we want tests to be sensitive. And this means that when the test is negative, we truly want cancer to be absent. And the holdup here is those cases where we have a falsely negative test result. That is, the test is negative, but there's cancer present. For pap smears and the detection of cervical cancer, pap smears and the analysis of the cells from the pap smear is relatively specific. There are some known false positives, but we often are able to see what those false positives are when we're looking at the cells that are obtained from the pap smear. At the same time, when a pap smear is negative, it's quite sensitive. That is, if it's negative, then it's very likely that there's no cancer present. There may be early premalignant changes in a pap smear, but a truly negative pap smear really does mean that cancer is very unlikely to occur. When we think about prostate screening, and I'm going to talk both about the digital rectal exam as a screening device, but more so talking about prostate-specific antigen, we have a bit of a breakdown because these tests are neither very specific nor as sensitive as we would like them to be. And then in the absence of good specificity and sensitivity, we're really relying on identifying people who are suspicious for prostate cancer and then having them undergo further tests that we might call definitive testing. So we have to, if a test is not very specific or sensitive, we need to have mechanisms of downstream testing that are neither costly nor create a lot of adverse effects. And this is a bit of an issue with prostate cancer screening, which I'll discuss in a few minutes. Just to introduce kind of the older version of prostate screening, this was done by rectal exam with the doctor's finger. Through the anus into the rectum, the finger is very close to the surface of the prostate. The lining of the the gut, the lining of the rectum, is the only thing essentially between the finger and the prostate. So this provides a way of assessing both the size, the relative size of the prostate, as well as the texture of the posterior surface of the prostate gland. Now, from what I've said before, you can immediately understand that we're really only assessing in a good way, in a high quality way. We're only really assessing part of the prostate, the rear part of it that faces the rectum. We're potentially missing other nests of cells, other tumors within the prostate that are in different locations. In addition, the size of the prostate can certainly increase with prostate cancer, but it's much more common for size to increase with BPH. So BPH is going to be on the order of 50 to 100 times more common than prostate cancer. So when we feel an increased size of the prostate, this doesn't necessarily mean that there is prostate cancer, although there are certain strategies for looking at the texture and the surface of the prostate that some clinicians can get very good at and increase both their specificity and sensitivity, but the average doctor doesn't have those skills. So in the end, this is not a very specific test for cancer, and particularly because it's really relying mostly on enlargement of the prostate, which is going to be so common with BPH. Where the real debate is now is that in large part, we've discarded digital rectal examination as a screening tool and rely much more on prostate-specific antigen. And PSA is a particular molecule that's continually produced in the prostate. I said earlier that this molecule may have a function in terms of keeping semen more fluid, letting it flow more freely than it would without the addition of PSA. So it's continually produced, and low levels of this molecule normally leak into the bloodstream, but at quite limited numbers. When the prostate is growing because of hypertrophy or this hyperplasia of the prostate cells, it increases production of PSA, and more PSA leaks into the bloodstream. Inflammation of the prostate also causes increased leakage, and this can be because of cancer, from prostatitis, or from BPH. And then finally, and what's most important in terms of prostate cancer screening, is that the disruption of prostatic tissue from the cancer produces even more leakage. So this is a situation where, moderately high PSA levels certainly require serial monitoring. And this idea of looking at the slope of PSA values is a statistical strategy to try to refine PSA testing so it performs a little better than it would be based on just a single PSA value. But if high levels are seen, then this requires biopsy. And this is often done with what's called an ultrasound or sound-guided biopsy of the prostate that's done through the rectum. So as I said before, during exam of the prostate, basically it's just the lining of the rectum that's separating the inside of the rectum from the prostate gland. This is an advantage for biopsy because biopsy can, in essence, punch through the lining of the rectum into the prostate to obtain tissue samples. And the rectum is not particularly damaged. It heals relatively well. The prostate itself heals relatively well. And this is a strategy for obtaining multiple biopsies from the prostate. Now, there are discomfort associated with the biopsy process, and there are occasional, adverse events that go on. One of the big problems, however, is that this is a relatively expensive process of both performing the biopsies and then analyzing all of the samples that are obtained through the biopsies. And in general, this seems like theoretically a really great idea, that we have a way of looking for increased PSA, and that if the values are really high, we think that, it's maybe beyond what would occur just with BPH, and we can detect cancer. The fact is that when we look at the performance of PSA and we look at population studies, most of the data is quite unfavorable. It really suggests that when we find cancer, and we do find it, that by and large, we're most likely to find slow-growing, low-risk cancers. And I'll show you in a minute a diagram which sort of maps out what this means for populations. I will say, however, that there's some very interesting recent studies that do suggest there may be more benefit of PSA testing than we had, in some sense, gathered from other studies. But let me just show you, and this will take a little bit of talking through, but what this depicts is 1,000 men who go about their business without any, they start at age 50, they go about their business without any screening at all, okay? And here are, in contrast, 1,000 men who are screened basically every year for 10 years, mostly with PSA screening, but some rectal digital examination as well. So what we see here is that in both groups, 8 men die from prostate cancer, okay? And a large number of men will die from other causes, and that we will have a relatively few people who are diagnosed with cancer because of the screening, so 20, and that those people will probably not die because of their discovered prostate cancer. On the other hand, we have 180 people, men, who do not have cancer, but they got a false alarm and they required a biopsy. So at the end of the day, what this group is suggesting is that at the end of the day, there are 800 men who are unharmed and alive, but in the group without screening, and only 600 who are alive and untouched by biopsy in the screening group. So this really suggests that we're putting in a lot of effort, a lot of money into screening that really has very little net benefit. And other studies kind of show the same thing. I do want to make the point that this is a complex area, and that some studies have suggested that if we look at historical data about the occurrence of prostate cancer, in several countries where prostate screening with PSA became very common, we do see a reduction in deaths from prostate cancer. So in some sense, we have some studies of a certain type which suggests not much results, not much good evidence of prostate cancer screening with PSA, and other studies that are questioning that. Those studies are not quite as strong in terms of their design, but they're very intriguing. So I'm just going to, kind of leave this open a little bit in terms of what the true answer is. But I think that we, over time, will get back to an answer. But that answer is not going to be that PSA screening does a whole lot of good. I think that one of the messages here is that it can detect cancer in some men. It does have an awful burden of biopsies in men who don't have cancer. And that we may want to restrict the use of PSA screening to men in a certain age group and to men who have high risk factors for other reasons, including some African Americans, those men who have the BRCA1 or BRCA2 genetic mutations, and some other instances. One other way of thinking about this is simply to look at what professional groups have suggested in terms of recommendations. So the U.S. Preventive Services Task Force is kind of the leading body on prevention services in the United States. And it's basically saying that talk to men who are between 55 and 69 and select PSA screening on a patient-to-patient basis, kind of knowing what they're getting into, knowing that the benefit is going to be small, knowing that they may be subjected to biopsy for not having cancer. They also say that men over the age of 70 should not be screened. And the American Academy of Family Practice, somewhat similar, except more negative. They basically say men over the age of 55 should not be routinely screened. So they're leaving room for the high-risk patients, the patients who don't follow the normal rule of thumb to be screened, but they're saying we really shouldn't routinely think about this. The American Cancer Society, which of course has been accused of being very self-interested in some of their past recommendations, even they say, we can screen, but it has to be based on how long people are going to live, what their risk factors are, and advising them about the risks and the small benefits of screening. So I think you can see that this paints a relatively negative picture, but there are some men who would definitely benefit from PSA screening. I want to go through this quickly because I realize that I'm running out of time, and I hope that I'm not shortchanging this too much, but in terms of prostate cancer, we have many options. One that I want to just make sure is understood is that active surveillance or watchful waiting is a completely reasonable strategy for a slow-growing cancer. Some of these slow-growing cancers, and we see that pattern on the biopsy results, are very unlikely to metastasize and are very low risk. That is, they're unlikely to really change the cause of death of this individual. Health behaviors can be a really important part of treatment, and they shouldn't probably be the only thing that a man is doing, but these anti-inflammatory changes can be very important. There are several surgeries that are done to remove the prostate if it has cancer within it. As I said earlier, the prostate gland is not necessary for human life. Radiation is often used as an adjunct to surgery. What this is doing is, even if the prostate gland is removed, there are the potential for nests of these malignant cells in the vicinity of the prostate and in the lymph nodes around the prostate gland. So radiation therapy is sort of a second strategy for killing off the cells. Hormone therapy is also very important. Most prostate cancer is sensitive to androgens, testosterone or DHT, and by reducing or shutting off completely the secretion of androgens, many prostate cancers will slow down. Chemotherapy is a standard treatment for cancer. Basically means that we're going to use a chemical that kills or slows cancer growth more than it does normal cells. Immunotherapy is a really exciting new area where we're basically enhancing our immune system's ability to kill off the cancer cells. And a kind of another new therapy is called targeted therapies. And what these are doing are looking at the steps that cancers go through as they grow, as they get to the point of metastasizing. And by interfering with some of these mechanisms, for instance, the formation of new blood vessels around cancer, these targeted therapies can really slow the growth of cancer. I'm just going to very briefly touch on prostatitis, given that I'm running out of time. Prostatitis is essentially the inflammation of the prostate gland, and it produces pain and difficulty urinating. Other bladder symptoms that can be similar to BPH, but BPH almost never causes pain in and of itself. So that's what distinguishes prostatitis. Now, this is a disease that, in a sense, similar to how I was saying with prostate cancer, is really several different diseases based on the cause. And these multiple forms each require different treatments. So acute bacterial is kind of the most simple and most treatable type of prostatitis, and antibiotics are often very good at treating it. Chronic bacterial infection is more complicated, and this in some ways is a inflammation that appears to be caused by infection, but antibiotics don't necessarily take care of it. It recurs or it continues at a low level despite the use of antibiotics. And then what's now called chronic pelvic pain syndrome actually is the most common type of prostatitis, and it's the least treatable. It, in some ways, is a bit mysterious, and we think that inflammation, probably on a systemic basis, that is the whole body, is focused on the prostate. So the prostate is adversely affected by something that's going on in the whole body. So I wanted to just finish by talking about going back to this idea of the role of health behaviors, because I think one really good way of thinking about the prostate is what's good for the heart is good for the prostate. And cardiometabolic problems within our body affect multiple organ systems, so that, we have these problems of inflammation, obesity, glucose control, and hormonal regulation that all tend to cluster together. And we see these in diseases like diabetes or fatty liver disease. But in essence, every single organ is going to respond differently to this particular problem of metabolism. So the heart tends to respond by building up fat in the lining of the arteries, making us susceptible to heart attacks. It also responds by increasing blood pressure. The liver, on the other hand, responds through fatty buildup, as in fatty liver disease. And we have the prostate that is also affected. And this process seems to lead to BPH, to prostate cancer eventually, and also to some forms of prostatitis. So I think the message here is that a healthy lifestyle has multiple benefits, including prostate health. And that what we're talking about here is a plant-based diet with high levels of physical activity and maintenance of a healthy weight. At the same time, those are the best proven parts of this, but I like to emphasize that things like good sleep, reducing social stressors, maximizing social support, and having minimal alcohol intake are also very important. important strategies. So I'm going to finish up there. I think it is about 8 o'clock, but I'm going to pivot at this point to talking about your questions. So the first question has to do with stopping PSA screening at age 70. So it's the issue here is, if we go back to what I was saying about what are the things that make for effective screening, we have to be able to change the natural course of a disease. The problem is, at age 70 and beyond, most people are not going to have a prostate cancer detected and successfully treated in a way that changes their life expectancy. First of all, they're much more likely to die of other things, and the prostate cancers that are detected through PSA screening are mostly going to be those that are lower risk. So this is a bit of a trade-off. Prostate cancer is increasing in those older ages, and in some ways that would be the ideal population, because it has the most cancer defined. On the other hand, in terms of what we can actually do to change the course of those cancers, we're very limited. So interesting question about BPH, because it's so ubiquitous in older men. Maybe we should just remove the prostate surgically, and this would both help us with BPH symptoms as well as prostate cancer. Well, there are a couple of problems here. One is that the routine mechanisms or strategies for reducing the size of the prostate in BPH usually leave behind part of the prostate. And this is particularly to minimize some of the sexual side effects of prostate surgery. But it does have this problem that you're leaving behind part of the prostate that's still going to be susceptible to prostate cancer. On the other hand, this reduction of volume of the prostate is going to mean that a larger number of low-grade prostate cancer can just be there, and we don't have to necessarily worry about it. There are some other strategies for looking at PSA in different ways. And I talked about one of these, which is not just looking at one PSA value, but looking at a whole series and seeing if there is an increasing slope of those PSA values over time. The greater the uniformity and increase of that slope, the more likely prostate cancer is behind that kind of change, because that's unusual with BPH itself. So there are some other types of strategies, including this idea of looking at the PSA molecule that's not bound up with other proteins as it travels through the blood. This may be a slightly more sensitive test, but unfortunately, it doesn't really shift the issue as much as we might like. So it's more specific, but it's higher cost, and it still has the problem of false positives. So there's a couple of very specific questions, and I'm going to have to say that, it's not my role to question whether other doctors are doing, but I think that, the sort of questions that are coming up with are the ones that should be discussed, probably both with a primary care doctor as well as with a urologic oncologist. Another approach to screening is to use imaging, especially sophisticated imaging like CT scanning or MRI. There are two problems with this approach. And it could be that over time we can solve some of these problems. One is that the approach of using MRI often shows us things that don't necessarily have a meaningful role in terms of affecting health. One sees this very starkly with MRI of the back, where MRIs will usually find something going on, and we can't trust whether the MRI is actually showing us the source of a person's back pain. And in fact, studies on people who don't have back pain show multiple lesions found by MRI in people who are not complaining of back pain. So we have a little bit of the issue when looking at the prostate gland. A similar problem is just the high sensitivity. We see a lot. We see things that look like cancer that are probably not cancer. And then finally, generally, this is a quite expensive imaging strategy. And again, to be used on a large population for a cancer that is affecting a small percentage doesn't make economic sense. In other words, there's no way for that strategy to pay for itself. So I'm going to thank people for attending. I also really appreciate the questions, and I'm sorry that I haven't been able to get to those questions. If you like, you can certainly email me at rstafford@stanford.edu, and I may be able to help you after we're done here. But again, I so much appreciate your attention and the great questions you put into the Q&A. With that, I'm going to turn it back over to James.
Thank you, Dr. Stafford, for sharing this great information about prostate cancer screening and treatment. And thank you to our audience for joining us and for the great questions that you submitted. If you like additional information or resources, please contact the Stanford Health Library. We hope that you'll join us for our next lecture. Good night.